Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect with your profession. I'm Nicole.
And I'm Leo. In today's episode, our guest is Dr. Rania Farhat. Dr. Farhat is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at St. Louis University School of Medicine. She's also the founder and medical director of the SSM Health and SLUCare Post-ICU Multidisciplinary Clinic, aka their PICS clinic. We hope you enjoy the show. All right, welcome to another episode of Acute Conversations, the official podcast of APTA Acute Care. Today, we have a guest, Dr. Rania Farhat. I'll read some information about her from her bio. She is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at St. Louis University School of Medicine. She is triple board certified, so that's in internal medicine, pulmonary disease, and critical care medicine. Her clinical interests are critical care outcomes, post-ICU syndrome, and PE. So the reason that we invited Dr. Farhat for today's episode is that I had heard about her through my co-host, Nicole Neveau. So Nicole had done a presentation over at Bridge the Gap and had mentioned the PICS clinic that they have, so the post-ICU syndrome clinic. And after listening to that presentation, I thought, wow, it would be fantastic if we both have Nicole, who is already one of our co-hosts, and Dr. Farhat on an episode to just talk about how this PICS clinic came to be, the trials and tribulations of getting it up and running, and how it's going so far. So Dr. Farhat, welcome to the show.
Thank you, Leo and Nicole, for having me on the show. I'm very excited to be presenting today.
Fantastic. So let's just start at the beginning. So how did the idea of a PICS clinic even get started? How was that initiated? Was that something you heard from somebody else? Was it something that you had seen working in critical care that says, in terms of follow-up, there's gaps in terms of our ability to be able to help with these patients?
Yeah, actually, the first time I got interested in post-ICU syndrome in general was during residency, when I was doing my internal medicine residency, and we had to present on a topic at the end of our third year residency. I picked post-ICU clinic, post-ICU syndrome, and that's how I got interested in it. Every time I read more about it, I was more interested in it. And then when I became a pulmonary critical care fellow, I was like seeing those patients more frequently, more closely. And then I started trying to get them to see me in my continuity clinic, which is a regular pulmonary clinic. And I started seeing those patients need more help than just coming to a pulmonary clinic. They need more services, they need more care. And then when I became a faculty, I told my division director that's what I'm interested in and that's what I want to do. So that's how the idea started.
Yeah. And I think I remember a story about having to do some activation around this clinic, and that it wasn't an easy yes every single go of the round, but you were able to find a way to make it work. Do you want to tell us a little bit about your journey?
Definitely. So this clinic is something, again, dear to my heart. It's my baby. So it took some time. It's not like when I first pitched the idea to the administration, they were excited about it. We were going through some transitions at the hospital, and it wasn't on the priority list. So eventually I had a mentor who suggested that why don't I use the help of the transitional care clinic that we have established multiple years ago at our hospital, and that was running really well. And since I would be providing similar services, as in this is a transition of care from acute setting, acute ICU setting to the outpatient setting. And I met with the director of that clinic, and they were very receptive to the idea. And that's how we started having a time and a location for me to see those patients. So they offered their location, their nursing, and their staff. And then I started talking to every different service by itself. So I reached out initially to Dr. Jennifer Anderson from St. Louis University Physical Therapy Department. And then at the same time, I contacted Nicole from our physical therapy at the hospital. She's the director of physical therapy at our hospital. And then we started putting the dots in place. Then I reached out to the pharmacy residency director, pharmacy resident director, and then he said, yes, we're interested in this. I have not met any person who I actually approach and they said they are not interested. Everybody, you tell them, you pitch in the idea, and they just, oh yeah, this is great, why not, we want to help in this. So it's been great, I've been lucky, and here we are.
Yeah, I think that goes to show we have a great infrastructure here, like you said, about that time and space, and able to just take each component as a separate hurdle and overcome them one at a time to bring it all together. A little bit about our transitional care outpatient clinic, or what we call the Bridge Clinic, which has been, like you said, established for a couple years, maybe 4 years, 3.5 years now. It essentially is a place for patients who need to have a checkpoint before they follow up with their primary or whoever their first point of follow up is post hospitalization. So it's really meant to bridge that gap. So if they're going to follow up with ortho in 3 weeks, ideally they would go to the Bridge Clinic at that 1 to 1.5 week point. Make sure you have what you need. They're also a great resource in terms of a phone number to call if your meds are out or any sort of hiccups are coming up. So that clinic has been, like you said, in place for a minute. So taking that opportunity to use the space, use the team that was already there, and build this in slowly, right? Because didn't you start with just one clinic a month, or I can't quite remember.
Yeah, we started Thursday morning a month, and then now it's on average every other week. Some months we have more clinics than others, but it's growing. So initially we were struggling to find the right patients for the clinic or to convince patients to come to the clinic. Now almost always we have a full schedule, which means that people are introduced more to the idea, they are accepting the idea, and they are also transferring the idea to other places as well. I have a couple of patients from peripheral hospitals who came to see me and they were like, we went back and we told them about you and everybody is so interested in this clinic. So I was like, okay, that's nice. I like it because I was like, I want to educate people more about what post-intensive care syndrome means. We see patients acutely in the hospital, but we have no idea what happens to them when they leave, right? Because we are critical care providers. I am lucky to be doing both pulmonary and critical care, but most people just do the critical care and then we don't know what happens. So this is a nice, again, transition of care. And for me, it's satisfying to see, okay, what I did in the hospital, is it working or it just worked for a short period of time? I want to see the progression of the patient, the progression of the recovery as well. This is more of a recovery clinic than just ICU. No, it's a recovery. We want to have this idea that this is about recovery. It's a journey. It's not one time only.
I think that's fantastic that you have patients that are doing your advertisement for you, right? They're doing their marketing, because in terms of word of mouth, sure, you could see the signs in the billboards, but when you have a patient that's lived it and then they're so appreciative of it and they find so much value in that, actually telling other patients, that's fantastic. It's great that you mentioned kind of the ICU situation, these patients down the line, but can you even take it a step back? I'm just trying to think for our listeners that maybe don't have as much experience in the ICU. What do these patients look like as they're going through this acute care process? And you had mentioned that there's the follow-up clinic before, some limited, and here you are looking at what are some of their other needs. I went to one of the CSM seminars a couple of years ago, and one of the things I learned is that it's important to screen for post-ICU syndrome, for PICS. Have you had any recent ICU stays if you're seeing these patients? And so I think it'd be interesting if you can maybe just explain what these patients look like as they're going through the acute care process, because even if it's just a couple of days, if they're very severely critically ill, there's so much sequelae down the line that can follow them for years.
Yeah. So the patients that we see at our hospital, they're very ill. You can think about them, the sickest of the sickest, right? They are sedated, intubated, on pressors, they are in shock, they have severe respiratory failure, some of them are on ECMO. So those patients are with us in the ICU for sometimes up to a month, if not more. So their life has changed significantly in this month. They went from maybe walking, talking, functioning, having high-level jobs to someone who's now bedridden, not able to move a muscle, able to breathe on their own. They need help with everything they need. Imagine someone taking all your freedom and putting you in a bed, right? So, and then the transition and the recovery is a very long process. It's not, oh, let's take the ventilator off, stop the sedation, they are not in shock anymore, and they're going to be able to go back to their prior level of functioning. It is a long process. And I make sure to mention that to the patients, to their families, because expectations matter. So for example, this patient had a respiratory failure, they were on the ventilator, we extubated them, took them off the ventilator. They go through transition of oxygen therapy from BiPAP to high flow to regular nasal cannula. And then in the meantime, they have started doing physical therapy and occupational therapy in the hospital. Some of them, you need to teach them how to swallow again. You have to teach them how to brush their hair. There are a lot of things that you have to teach them to do again. And then after that, when patient goes to the regular floor, not in the ICU anymore, they start thinking about, okay, where do we go next? Are we going home? Are we going acute rehab? Are we going to long-term acute care facility? All of those are actually, the transitions of care is prolonged. It's not one day at a time thing. And then a lot of patients between those transitions of care, actually they come back to the ICU or they get readmitted to the hospital, unfortunately. So there are a lot of studies about this. A lot of patients there was a cohort study done a couple of years ago at Duke. They followed 110 patients who had respiratory failure, were on mechanical ventilation for more than 4 days, and they were all young, like between 30s and 60s. And 10% of those patients were actually back to work at 1 year. Only 10%. So this is a huge morbidity, right? If you can't go back to work, you can't afford your insurance, you can't afford coming to your appointments, you can go back to your life. So that's why it's very important to capture those patients and make sure that you are offering them the services that they actually need.
I'm so glad you brought that study up. I was actually going to ask you, that's such a significant reference. And I'm pretty sure we can put a reference to that in our minutes here for the listeners as well. I think you and I have talked about this before in terms of this idea of failure bias too, that when we are acute care therapists and physicians working in critical care, and we see these patients who start to do well, and then maybe they backslide a little bit and they do well again, or they might even go home and get readmitted. We really only see the failures. And those patients, that 10% that do get back to work within that year, we don't always see that. So we don't get to mark what was successful, what did we do well, so that we can maybe turn that 10% into 20% or higher.
Exactly.
So I love that part of the staffing model for this clinic here is involving staff that do work in our ICUs. It's involving learners as part of the various ancillary residency programs, your residents. I think it's critical that we're looking at the whole trajectory of quality of life, not just mortality in the ICU, but what is that 1 year follow-up? And then the other thing I was thinking about when you were talking is that for us in acute care, this is our everyday, right? We kind of joked about this, like we don't even want to go home and watch it on TV sometimes.
Exactly.
It might be great, but sometimes it's just too much. But for our patient and for their caregivers, this might be the worst thing that's ever happened in their life.
100%.
And really remembering that at each step of the way.
And that's why there is also not only post-ICU care syndrome, there is a category that calls post-ICU syndrome family.
Yep.
The families also can have that. Yes, because imagine not everybody is aware of the medical field or what goes on in the ICU or how patients respond to a certain treatment or fail certain treatments. So when families encounter that firsthand, it's a lot for them to take in, right? They see their loved ones. Again, like I said, they are fine one day. The second day, they are just bedridden, agitated, delirious, not able to breathe on their own. They are their color is changing, their skin is changing, they're not able, they hear us asking the patient, can you move, can you wiggle your toes, which is a simple thing, but for them it was like, yeah, they can. Why are you asking them this question? But for us, it's something that we need to assess certain things. So for them, it's just it's flooding of new information that they, at the same time, they are not able to comprehend well. So it's not only about the patient, it's about the family. And something I say to the patient was like, you need to take care of yourself during this time. You cannot be at the hospital 24/7, awake, not sleeping, because when your family member, the patient, gets well, they need your help as well at home. So they're not, you will, if you get sick, they're not going to be, nobody's going to help them, right? So that's what post-ICU syndrome is for. It includes the patient, adults or children, and their family members as well.
Yeah, it strikes me too is that so I've done some cross covering in PICS clinic as well. I know I'm definitely not as great as Dr. Anderson or Natalie Stevens is our OT who all covers over in that clinic and does and presented at Bridge the Gap as well. But one thing that I take note of each time is your diligence in asking the patient and the family about what they remember about their stay in the ICU. And I feel like I get a little teared up even thinking about it because it's such an important component of that post follow-up. You sit down and you tell them in plain terms, step one. And do you want to talk about is there evidence behind that? How did you come to get to that habit?
Because there's no evidence behind this. It's just, what I do is I try to, and I tell them, I'm trying to connect the dots in your brain. Okay. I want them to understand what actually happened to them, because there are a lot of patients who get to me to the post-ICU clinic despite seeing multiple specialists after their discharge, and they are clueless of what happened in the ICU. We are creatures of, we want to know, right? Everybody, we love to know. So you need to tell them what actually happens for them to come to closure to what actually happened. And sometimes, like I asked, like he said, specific questions. What do you remember? Most of the time, they don't remember anything. Actually, they think that they said, we had nightmares. And then I don't stop there. I was like, okay, so can you tell me about those nightmares? And then they were like, oh, it's not important. I was like, I just want to know, just tell me a bit more. So most of the patients tell me something, and it's been a recurring theme, is that we actually dream about being in an unknown place and we are naked and strapped down. So I tried to explain to them, when you were in the ICU, you did not have clothes on, you just had a gown or a sheet, and then you were restrained. So I think when you explain things to them, that now things start making sense in their brain. It's not a nightmare or a scary idea as much as it used to be. There are a lot of patients say things that I am shocked with. I was like, oops, sorry. For me, on a different, like when we're in the ICU on that side of things, like when patients leave the ICU, it's a success for us, right? Yes, patient is alive, they are better, they moved on. But then I see the patients in the clinic and I was like, I asked this question, I was like, I want to see what's the impact they got from this. How did this experience impacted them? So that's why I ask those questions. And then it starts happening that patients start saying things and then the family starts correcting them. And then there are some evidence about ICU diaries. The evidence is controversial. Some studies were good about it. Some studies did not show much outcomes. But the thing is, patients are different, right? There's no two patients the same. So when we try to include them in one study, it's really hard to see who actually benefit from this intervention and who did not, because the experience is different. Whatever your history prior to this hospital stay is different. So some ICU diary studies showed some benefit, and that point is reminding them what happened. So the family member would be writing every day what happened for them during that day, and then when they leave the hospital, they read that diary. And some studies showed it helps. So that's why I try to ask them.
Yeah. I think that's great that you had mentioned the things that they do remember and things that they don't remember. What's interesting about, I guess, just kind of looking back at what we look at as success from a physical therapy standpoint, like what are our metrics that we're looking at? Was the patient mobilized? Were they extubated? Early mobility, right? Wow, that's great. We got them to take some steps while they're still intubated. Great. And then the big thing, and I can also attest to my ICU nurse friends, it's like, hey, they're doing well enough from a medical standpoint, we can get them out of the ICU. Woohoo, like cheer for us, right? But it's funny too, like that's our barometer of success. What we don't look at sometimes, okay, so what happens when they did get the general medical floor? And then did they go to rehab, or did they go home, or did they go to the LTAC? I think one of the best memories that I had that I think also drew me to acute care is I remember as a student seeing a patient in the ICU. They eventually went to rehab. And maybe about a couple months later, when I was done with that clinical rotation, I saw him out in the community and he was like grocery shopping. But I could tell though he was still a little bit confused from what what the family told me. Like he was totally independent, but he was there with his son, and his son was helping him read the labels of. And I think his son was actually, oh, go get me a thing of gravy or cranberry. It was right on Thanksgiving. Let's go find the cranberry sauce. And I think they had learned that from day rehab. But it was funny to think, oh, okay, now I see this patient out in the community. And for me, like, this is fantastic because I saw him when he was bedbound. This is success. But there's so many other different layers, right? Like,
Yeah.
I love doing this podcast just because I learned, because I had no idea what PICS family was. I just learned that today, right? And just hearing more about kind of that 10% that actually get to that prior level of function.
Yeah. And I think, Leo, I'm just going to build off of what you were talking about, seeing those patients along the continuum and what it does for us as critical care therapists, providers, all along the way. I was telling Dr. Farhat, we do a grand rounds here in our therapy department, and literally an hour ago presented on a patient that's being followed by Dr. Farhat after his hospitalization back in, I think it started in February. And so he's had a couple follow-ups, and being able to follow the cases in such a way to see, okay, this person left the hospital, and our acute care therapists were cheering about walking 10 feet in a Sarah Plus, right, with a harness on, and getting this patient to an acute rehab setting, despite the incredible amount of debility that this patient had from a prolonged ICU stay. And now knowing that at the last clinic visit, he did 2 flights of stairs. And so from a PT perspective, this is something that we put on ourselves, but actually we have a OT in our clinic that does a lot of the outcome measures.
Fantastic.
And it's been very enlightening to get that occupational therapy perspective, because here I am cheerleading, 2 flights of stairs, then that's great on room air, right? But the OT is there measuring things like fine motor skills and quality of life, and a couple cognitive assessments that are, as well as the gross dynamic balance and mobility. Dr. Farhat, you just gave a presentation to your residents and fellows too on manual muscle testing, right? That I went to.
Yes.
So it's like, how do we marry our professions so that we have common language about what success is? I know one of the outcome measures that we're looking at grip strength in the PICS clinic, and I know you're looking at that in terms of age norms. Is there anything that you're looking at in particular around those outcome measures?
Yes, so something that also we measure closely in our clinic is the 6-minute walk distance, because it's one of our objective measures to test the patient's physical endurance, right? How much they are able to, because you ask patients, and this is also from the pulmonary literature, you ask them, how much can you walk? And they're like, we're good. But then when you make them take the test, a lot of them are lower than the lower limit of normal. And actually in our clinic, in August, it would be 2 years since we started this clinic. I had 2 patients in this whole time that are actually higher than the lower limit of normal on their 6-minute walk distance. So the perceived physical tolerance for patients is completely different than what they can do and they cannot do. And then it just tells them, they think they're doing good. You tell them, yes, you're doing good, but we need you to do better because there's still room for improvement. That's the thing, is that if you don't see that there's room for improvement, you're going to get discouraged and you won't be going to more exercise sessions, go to the gym, try more. That's the important thing. Keep trying. And then we know physical mobility. I did this lecture for the residents about early mobility in the ICU because, again, I'm so passionate about it. I want patients I want awake and walking ICU, right? It's a thing. And unfortunately, during COVID, things went backwards with that. So I keep encouraging and I keep teaching. And like literally last week, a resident told me, "Oh, the patient can do physical therapy when they're on the vent." I said, "Yes." it's it's just like we had multiple steps backwards with that because we were doing so good a couple of years ago with early mobility, and now unfortunately we're not doing well about that. And we know early mobility in the ICU improves outcomes, improves cognitive function, decreases delirium. It improves a lot of things. So that's why I'm passionate about that. And then we measure, we look and see, okay, I look when I see this patient in the post-ICU clinic, we look at the last note from PTOT before they left the hospital. What were they doing then? Is there an improvement since they were last seen by PTOT? If they went to rehab or if they did not, if directly they went home? Like, has the patient been improving? Because that's the thing. It's about recovery. It's not, we don't stop there. We have to keep going. So the measures that you ask about, yes, the 6-minute walk distance is something that we look at. We'll also look at their cognitive function, their slums test. Again, a lot of patients, they don't perceive that they are not remembering as much as they used to. Family members, they perceive that and they can notice that. The patients themselves, they can't notice it. There are a lot of things that I remember a couple of weeks ago, we had a patient who was like, "I'm doing great, actually. I don't need this. I just came because they told me to show up." His slums was 16. I was shocked. And he was like 59. So it's not like he's older or demented at baseline. He was functional. And I was like, okay, let's go through those numbers. Those numbers are like, they give me an introduction to tell the patient more about post-ICU syndrome, to tell them, yes, you went in for pneumonia, you were on a breathing machine, but then there are other impairments that can happen during that time, and that's why we need to screen for them and direct you for the right specialists.
Dr. For our listeners out there, when you mentioned the slums, could you explain a little? Because you said 15. Is that good or bad? Based on your reaction, that was not a good number for this person to be having. So could you explain that a little bit?
Yes, so it's this St. Louis University mental stats exam, and usually you get a full score when you're up to 30. If you have anywhere above higher level education, if it's more than 27, it's good. If it's less than 27, it's bad. And depending on your education level, we know what's good, what's bad. This test was initially done for dementia screening, and it's only a screening test, is not a diagnostic test. It's a screening test, and it is validated in dementia. It is not validated in post-ICU syndrome and cognitive impairment. But again, it's a screening for us that most of the post-ICU clinics around this country uses to screen those patients. And then next step would be referring them to the appropriate specialty.
Thank you for that.
You bring up that you are interconnected through a group of nationally set up PICS clinics. And I'm not telling you to name any names here, but potentially if there are listeners that have their smaller, medium-sized hospitals that want to set up PICS clinics, is this a resource or that they can access?
Definitely. It's the Cairo organization, Critical and Acute Illness Recovery Organization. Now they just started. They used to have yearly applications to join, and now I think it's rolling all over the year. Actually, they were the most helpful thing in my journey so far, because it's just a very laid back meeting that we have once a month. We meet, we discuss about our clinics, we ask questions how they are doing it at other sites and how can we improve what we're doing. It's purely helping build more of those clinics and make them functional so that we have more patients have access to those services.
And then and for the both of you, I'm just wondering, what is, in terms of numbers, what's the percentage of those patients that go to the ICU that have PICS or then critical care? What's the capture rate from PICS clinic and then followed through all the way up to, from ICU all the way to PICS clinic? Because I know even just for, let's see, even just a general acute care stay for a patient, I feel like once they leave the hospital doors, just being able to get any follow-up or continuity of care can be difficult. We see this with heart failure. We see this for a lot of different diagnoses. So in terms of that capture, what does it look like from the ICU over to the PICS clinic?
I mean, I can already start. Let me start with a little bit of background in there that we accept transfers from a very wide region into our ICU.
Yes.
So maybe it might not be the same for every hospital, but a good portion of our critical patients come from outside of our region. So
Because
coming
there's probably nothing for them that's available close to them, right?
Yeah, and that's a national crisis that's going on in not necessarily the scope of this podcast, but I think having that understanding helps to understand the barriers that can happen with accessing a St. Louis-based clinic. Now, go ahead. I'm sure you have more of the numbers.
Yeah, I don't have an exact number, but I know that anywhere between 60 to 70% of patients who are admitted to the ICU, they are diagnosed with one or more impairments in the PICS domains. And this is in a cohort from Vanderbilt, and there was another cohort in Japan showed very similar numbers, anywhere between 60, 65 to 70%. I'm just going to give example of what we see in our clinic. Maximum we see 8 patients in this clinic. Okay, we are a medium sized hospital. I can tell you for last month we had around, on one of the floors in the ICU, which is only 20 bed ICU, one of the ICUs that we had anywhere between 90 to 100 patients during that month. Okay, so just look at the numbers. If just half of them have post-ICU syndrome, those are 45 patients, right? I think only 8 of them, if any. So
yeah, so trying to make a small dent in a huge problem. And I think that also comes back to the education component, not only for the patient and the caregivers, but having a concerted effort on our teams. For example, here, having grand rounds where we are presenting the outcomes from a patient who has gone through the continuum, not only to reduce failure bias, but also in terms of education of what is the PICS, what is the PICS clinic, and what can we do on the front end to avoid PICS altogether. And then if we can kind of get to a place where then we're talking about referrals, who might be a great patient for this longer term follow-up, starting those conversations at a level that is more granular than what we can access in one clinic, in one hospital, and with one doctor. And then having you on this podcast and talking about it at Bridge the Gap to say small, medium hospitals, large hospitals, rural hospitals, academic medical centers, what are some of the ways that you can have this type of support service, either virtually or in person? I think some of them are virtual, some are combo. How do we disseminate this information upfront and to the family right away and long term? What are we doing in terms of disseminating the education?
Yeah, I definitely agree. Education is key here. So there are a lot of efforts that are being done. So now I have medical students coming to this clinic. So we're starting early. If you start teaching them when they are medical students, when they become residents and they see those patients in the ICU and take care of them, they will understand what that means. They will understand the impact of what they are doing on the longer term. Same thing with PT and OT students, with PharmD students. All of it matters. You start with the education. Education is very important. When you start early, they will start noticing things more, and they will start thinking, it was like, that's what we learned about in the clinic. We have to prevent that from happening. How do we prevent it? That's how we start critically thinking about the treatments or actually what you're saying in the patient's room, or what medication you're giving to the patient that might have negative outcomes or have negative impact on their delirium and all of that. Or early mobilization. That's why we're doing early mobilization, because it decreases delirium. All of those things matter when you start early on with the education. You don't have to educate only critical care fellows. You have to educate medical students and PT and OT students about that. That's one. Two, there is now, it's a nationwide effort through this Cairo organization to have Walk for PICS. And it's in September, and every year they are doing that across the country at different locations. And you can actually, I can share the link with you so that people can see which locations they're having those walks so that they can join. Again, this is an effort to teach the community about post-ICU syndrome, because patients don't know. If doctors don't
Mhm.
know and therapists don't know, patients don't know. So
Right.
you have to educate at all the levels. It's not only you educate the doctors or the physical therapist or the occupational therapist. You have to educate everybody about it to start doing something about it.
Thank you. Thank you for all your advocacy, for your education, for agreeing to be on here today. I know I shared with you at Bridge the Gap how welcomed this presentation was and how many
Yes.
questions people had about you in particular, about your advocacy and just hearing the passion through your work as we disseminate as far as we possibly can to help spread this message with you. Is there anything else you want to share before we
No,
start wrapping up?
I just want to say thank you. Again, as I said, this clinic was my baby. I'm very passionate about it. Just starting to disseminate the information and the education is very important. And I'm always, Nicole knows, I'm always happy to help. Anything that actually impacts the patient's lives and impacts this long journey of recovery, I'm there for it.
Dr. Farah, I want to ask, do you have any fun stories about patients that you followed through from ICU all the way to the PICS clinic?
Fun stories. Oh, wow. Most of the patients don't remember me, even though I have talked to them about post ICU syndrome before they left the ICU. Like when they were awake, when you think they are awake and oriented times four. And then I explain it to them. When they come to the clinic, they have no clue. Nothing at all, seriously. So I was like, okay, maybe whatever I say in the ICU does not matter doing at the clinic.
I don't
So
know that you'll find a therapist who doesn't have that same story.
they forget everything that you teach them in the ICU, right? So yeah, it's just funny stories. I wouldn't say they are funny. I feel like now I just relate to what patients experience more because I was like, I'm hearing it. They are delirious, they are agitated in the ICU. And then when they come to the clinic, they tell me things. And I was like, now it makes sense to me what they were going through and why they were acting that way. So, but funny stories, I can't remember anything right now.
Thank you again for being on the podcast and sharing your stories and sharing the information. And again, our goal is to disseminate this knowledge to all of our listeners. And so if there's listeners that are out there, if you have questions, if you're interested in the idea of a PICS clinic at your hospital at whatever level, whether it's a large for critical care hospital or small community hospital, yeah, let us know and then we'll put you in the connect you to the right people.
Yeah,
I
thank
think
you.
it's time, Nicole. So we're gonna end now what we call rapid responses, Dr. Farhat. We're going to get the timer ready. And the fun part about this is that just the first thing that comes up to your mind, just go ahead and answer
Okay.
the question. You ready?
How long do I have to answer each question?
Yeah, I think it's 10 seconds per question.
Okay. Okay.
Right away.
So procedural. You're like, I want to know all the rules.
Yeah,
What's the standard
What
procedure for
to
this here?
get to.
yes.
All right, Nicole, do you have a question ready? I'm gonna start the timer.
Sure. Okay.
All right, let's do it.
All right, Dr. Farhar, what is your favorite type of weather?
Oh, summer.
Summertime. Dr. Farhat, what type of shoes do you wear when you're on the acute care floors?
Running shoes.
Running shoes? Do you have a particular brand?
I like Brooks and I like the New Balance, the jelly.
Brooks.
Yeah.
Nice.
What was your least favorite class in high school?
Ooh, history.
If you were not a critical care doctor, what profession do you think you'd be in?
Pass.
Yes.
Doctor, that was only the ever
There's no
only
other.
answer.
No, there's something, but not for now. Let's say engineer.
There we go, engineering.
To fit within the family.
Oh man, do you have a favorite type of board game?
Chess.
If you name a movie that you can recite, you can say all the lines from the movie.
A Walk to Remember.
Nice.
Oh. And then do you have a favorite word in a different language?
Oh, yeah. So my native language is Arabic. So Alhamdulillah, which means thanks God.
Aw.
Very nice. After a long day of working, whether it's at the PICS clinic or whether it's in the hospital, what's your favorite meal to have?
Ooh, something Lebanese.
Lebanese food, very good.
Yes.
Awesome.
And then I
And
think our
Nicole,
final question here is what you're an acute care or an ICU provider when, and then finish the sentence.
When I comment on every scene on a medical show.
positive and negative, right?
Yes. Yeah.
We were just talking about that before we started recording. It's just like all these, especially when you have family or friends like, oh, did you see this episode, that episode? I'm like, I just spent 12 hours in the hospital. I don't need any more hospital stuff to weigh my brain down.
No, my husband, who's not in the medical field, always comments that if we're watching any show and there's any scene that passes in the hospital, you're gonna butcher it. And I said, yes.
Does he know? Was that because in the past you were like, that's wrong, that never happens, nobody does that?
Yes.
So he's ahead of the curve.
The most ridiculous thing is every cardiac arrest gets electric shock.
Yeah.
True.
I was gonna kick when people get like, and then they're like, oh, okay, now what are we gonna do now? They're completely, totally different than what happens in the hospital.
Yeah, definitely.
All right. Oh, Dr. Farhat, if people have questions for you, where could they find you? Do you have social media, or is there an email that you could share?
Yes, I'm on LinkedIn. I'm on X, previously Twitter, and I will share my email address with you guys.
We'll put in the show notes. Awesome.
Thank you so much. Appreciate your time today, and can't wait to work together next time.
Thank you so much for having me again.
Awesome. Thank you.
We would like to thank Dr. Farhat for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leora Quellis and Nicole Naveau. Executive produced by Katie Rito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, including our new tagline, Optimizing Recovery, Elevating Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for a conversation with our 2026 Acute Care Lecturer awardee, Barb Smith. Thank you for listening, and may your shoes and scrubs stay clean today.